shining bright. My body's telling me it's gonna be alright. I'm getting stronger each moment. I'm feeling no pain through knowledge and power. I know that's the way. I can receive my healing, 'cause we need it. We need a healing. Come on and receive it. Receive my healing, 'cause everybody needs it. Oh, one more time and receive it. Hi, I'm Dr. Lenora Coleman, President and founder of Healing Our Village and Executive Director of Total Lifestyle Change. I want to welcome everybody out there to For Your Health. It's all about your health. Somebody was talking to me a few minutes ago and asked me, why do I come here on Saturday instead of laying in bed and relaxing? And so what is my why? Why do I do this? And by the way, for those who don't know me, I've been at this for over 40 years. And the reason why I do this is because my pastor actually died of sudden death in the 6 o'clock service in the pulpit. I wasn't there that day when he died. I was actually traveling. Came back that next Sunday and was filling out my envelope or my tithe. And the preacher that was in the pulpit said, and the viewing of Pastor Henry will be today at 3 o'clock. And so I stopped writing and I leaned over to the lady next to me and I said, did Pastor Henry die? And she said, yeah, he died, sudden death. Couldn't resuscitate him. He had hypertension. He had some diabetes, he was overweight, and a lot of stress because he was a bishop. And all of that put together took this man out of here at 58 years old. See? And that's not what we're supposed to be doing. So that's my why. And so I am so happy that you all are here today because you're helping me fulfill my purpose. My purpose is to stop the death and dying. My hashtag is no more funerals. And so that's why we're coming to you with For Your Health. For Your Health is a medium. Now that we have internet, now that I can do this live on Facebook, I can record it, I can post it up. Now you all can share this information with your friends and family so we can stop the death and dying. So this is February. February is Heart Month. And so all this month I've been bringing to you the leading experts on hypertension and heart failure. And today we're going to be talking about peripheral artery disease, and we have one of the leading cardiologists in the country who happens to be based in Mississippi. And as you know, when you talk about the southern states, we call it the stroke belt, okay, because folks in these areas are having more death and dying and more heart attacks and stroke than anybody else. And so today we have Dr. Fakorede. He is from Mississippi, hailing originally from his family from Nigeria. So we talked about Nigeria a little bit before we got started. So thank you so much, sir, for coming here today. I appreciate your time.
Blessings. Good afternoon, Dr. Coleman. How are you? How you doing?
I'm doing good. I'm doing good. Hey, I told you my why. I want to hear your why, because I know that this is a mission of love for you.
Well, it's, first of all, thank you for being a health champion and for the sacrifice in terms of continuing that, being a servant leader, and carrying on this apron of humility to serve your community and to affect outcomes. For me, it was easy. Having trained in the northern region, the northeast region of the country, we were well familiar with all the cardiovascular metrics and the dismal outcomes when you look at the Black census scope of America, meaning the Black map of America. And it's by no chance that this occurs predominantly in the southern states, because historically, if you look back to the antebellum, back before slavery, and still evident today, the remnants are still evident that majority of African Americans are found in southern states. Unfortunately, there was no equity to bring them to par in terms of the economic upward mobility, educational upward mobility, health provider and access to quality care upward mobility that's needed. They were rather inundated with food deserts, and given a social context and a physical environment and neighborhoods that redlining did not do any justice to, where they were located in a lot of rural areas. And so, other than just big cities like urban cities like Atlanta, Birmingham, Charlotte, like every other area did not see that big upward mobility to the middle class.
Right.
And what you see rather is you see that they carry the heaviest burden of cardiovascular diseases, heart disease, vascular disease. You look at amputation rates, for instance. You look at dialysis rates. You look at stroke rates, as you mentioned, and obesity rates. So,
Yeah.
as a cardiovascular specialist, it only made sense as one of the few black interventional cardiologists and endovascular limb salvage specialists is to come to a community that not only carries those statistics, but also a population that heavily reflects, the physician, where you can engage them and see how you can affect change. And that's why I came here to Cleveland, Mississippi, to serve not only this county but all surrounding counties with a 180-mile catchment area.
Yeah, exactly. So you're at ground zero, and this is
Yes,
this is
ma'am.
it is it's true, and I really applaud you for that because like you said, you got your training up in the north, right? You could have very
Mhm.
easily stayed at one of those academic medical centers, where things are a lot easier to do, but you decided to sort of come back and do this in the community in one of the hardest hit areas. Mississippi is I've been there, I've traveled there, you come and do lectures there, and so I've seen your healthcare system there, and
Right.
there are some areas where they don't get health care, right?
Yes, there are counties in Mississippi that do not have provided coverage. There, one in four African American adults in this state are uninsured. The state did not take on the American Care Act, right?
Right.
Affordability Care Act. So, and Medicaid expansion did not even exist. Even in the topic of amputations, it's funny that we talk about Medicaid expansion, but even with Medicaid, you're restricted in terms of medications you can have in a,
Yes.
in a, in a, in a desired month. And for an amputee in the state on Medicaid, it's very hard for you to get a prosthesis that is covered by your insurance.
Wow.
So those are just little things that you see, and you look at basically the state with the lowest number of physicians per capita and the poorest state in the country, and you put that all in one pot with everything else that we just talked about, and you look at the burden of health in the country, you see a significant reduction in cardiovascular deaths from 1990 to 2016, 2017 in a lot of the regions in the country whose zip codes do not parallel our zip codes.
Right.
But you do not see those same numbers
Nope.
in our neighborhoods. You're seeing increasing amputation rates, increasing heart attack rates, and increasing dialysis rates. Even the incidence of breast cancer is not high, but the death rates from cancer are high.
Right.
Infant mortality is high. So physicians just need to understand that rather than the Doctors Without Border, where we're going to international countries, we need to focus on
Yeah.
our rural health systems here because
Right.
we have the pandemic existed here before pandemic that we're seeing with COVID-19.
Exactly, exactly. So I really was excited about doing this topic today because we talk a lot about cholesterol and coronary artery disease and coronary heart disease, but we never talk about peripheral artery disease, right?
Right,
And
right.
that to me I think is a shame. So I wanted to take a deep dive into exactly what peripheral artery disease is. You spend a lot of your energy really focused on that. So tell the audience sort of what is peripheral artery disease.
Yeah, that's a great question. So cardiovascular disease has a bunch of disease spectrums underneath that umbrella, and one in three adults actually die from cardiovascular disease. And what is the definition? Is basically a constellation of the buildup of plaque and cholesterol in your arteries outside the heart that leads to the narrowing of the blood vessel. So you have a buildup of what we call waxy substances that look like this, right? Bad. That's bad.
It's
And
bad.
the risk factors that accelerate these are your diabetes, high blood pressure, high cholesterol, your nicotine use, any other plaque buildup you've had in your neck or in your heart can lead to circulatory deficiencies of which oxygen blood flow to your extremities. And when that happens for a long time, it manifests with symptoms in some, and some just do not know. It's a silent disease. 50% of patients do not have symptoms. Another 15% will have pain when they exert themselves. And then some present with ulcers and wounds, and that's what we consider the late stage of critical limb ischemia. And so the constellation of that is what we call peripheral arterial disease. The analogy is the heart. When you have this in your heart, you have heart attack.
Right.
If you have this in your neck, you have stroke.
Right.
Well, if you have these in your legs, you have leg attacks, peripheral arterial disease. And if it's not diagnosed on time, it can lead to an amputation.
Exactly, exactly. So there are sort of these stages of how patients present to you, right? And
Yes,
you
yes,
already said stage one is sort of the asymptomatic stage,
right,
but sort of go through the progression because, like you said,
right.
people don't even know it's happening, right?
Right, right. Yeah, it's it affects 21 million people, and in the country, and the majority of whom are minorities. If you're an African American, you're twice more likely to get that than your non-Hispanic white counterpart. And what we see is that our early stage, if you can walk over 200 meters, then you're still in the early stages. If you don't have those symptoms, with numbness, tingling, burning, or fatigue when you walk, or your leg gives out on you. But if you can walk less than 200 meters, then we're seeing symptoms that are leaning towards symptoms that you'll get at rest, which is the third stage. Sorry, the fourth stage. And the fourth stage is where you have symptoms at rest. So the previous stage I just mentioned, where it's with meters at 200 meters or less, that's called claudication. And then at rest, we call that, the onset of critical limb ischemia. And then stage five is where you have a non-healing wound, an ulcer that you see on your feet that, it's like there, and then it leads to gangrene, which is the end stage where you lost. And those are the stages of peripheral arterial disease.
Yeah, it's interesting because, as you know, I do diabetes, and so I'm a certified diabetes educator. When I was in California, I come from California. I worked very closely with a lot of podiatrists in
Hmm.
California, and what shocked me was people would actually come to that podiatrist office, and their toes were black.
Yes.
Okay, so now I'm trying to figure out, all right, were you
And
thinking
what
was
happened?
happening when it
Yeah.
was
Well,
like turning a little bluish gray, you
I
know?
know, I know, I know, but you mentioned something, right? So there's something called the amputation lottery, and the amputation lottery is basically certain characteristics or geographical location or demographics that determine if you lose your limb. So one is geographical location, the number of vascular specialists, such as myself, or specialists such as yourself, or a podiatrist, or endocrinologist, people who can take care of your risk factors. Are they
Right,
available in your region? Does your hospital do a lot of volume of limb salvage work where they can prevent that progression? What's the literacy level of the health literacy level of the patients, and the average health literacy, for them to understand that that progression is not normal?
no,
What are the other practical reasons or economic? If they live 2 hours away, are they gonna, they're gonna go from that numbness and tingling and that pain to accommodating to the onset of symptoms, to where they know when those symptoms are gonna come on, and so they'll walk all the way to where they know, well, I go beyond this spot, I'm gonna have pain, so I'm gonna be limited,
right,
and they're gonna stay right there until it progresses to the
yes,
next stage.
yes,
And then the other thing that happens is the mistrust with the healthcare system. We forget that. Let's not forget now. There's a huge mistrust between certain communities, especially communities of color, and the healthcare system. It predated custody. If you go back to slavery, when gynecological procedures were done on females, right,
right,
without anesthesia, to the 1918 pandemic, where African Americans were not given, the treatment for pandemic flu.
right,
And then you bring in Tuskegee in the 1930s to the 60s, and then even after that in oncology and in the cancer world, in terms of informed consent and adequate treatments, they were not adequately given. And then you add on to the cost of care, of access to care, access to medication? Can they afford these things? Based on their social determinants, and you add racism on top of that.
Right.
I mean, those are factors that you wonder, like, wait, how did you miss that? Well, let's go back and see what were the steps that, did you know you were diabetic?
Right.
Did you know what your sugar levels were? Were you monitoring that? Were you taught how to eat, how to exercise? Do you have the amenities around you to even do those things? So that whole constellation of symptoms is why we see what we see. Because these patients don't know what they don't know. And so until you and I go out to the community or have events like this to teach them what those things look like or should not look like, then that epidemic continues.
Yeah, yeah. So I right now what I'm really focused on with No More Funerals as my hashtag is stopping the heart attacks, stopping the strokes, stopping the kidney disease, and stopping the amputations. You just named my four biggies, right? And if we treat the cholesterol, which my show earlier today was on cholesterol, if we treat that cholesterol, get rid of that plaque that you
Mhm,
showed in that vessel, then we're going to
mhm.
be able to get there in terms of decreasing and preventing those big four. One of the things that I noticed though when I talk to my women that have are getting older and they present differently than men do. Have you noticed that in your practice in terms of
Yeah,
symptoms?
yeah, that's true. We're seeing that not only in literature, but peripheral arterial disease is also a disease of aging, where the older you get, the higher your plaque buildup, right? The progression of plaque buildup starts, when we're young, and then if you are a smoker or you dip or you chew or you have high blood pressure that's not controlled or your sugar is not controlled, it speeds up this plaque buildup, right? And
Right.
it closes up the vessel, so you're not getting good oxygen flow. But what we're seeing in women is that women are ignored. They're ignored when it comes to heart disease. They're ignored when it comes to their symptoms of their legs. I have a predominantly African American population, but 60% of my patients are females. I think the loss of estrogen too, that protective effect that we see in the heart is in play too later on in terms of the rate of
Okay.
progression of
And
plaque,
what's going on? What are you doing?
postmenopausal. Um, and then you also see that in these women, um, when they go in, their symptoms are atypical, and when they're ignored early on, it's you miss it, and then they present late stage, and some of their symptoms are even they're different. Just like in the heart, they come with fatigue. Their palpitations sometimes, but sometimes they're just tired. Sometimes it's lack of low energy, and shortness of breath. They don't come with men like the crushing chest pain. Well, in the
Yeah.
legs, you see the same thing. It's just atypical, and we need to do a better job at checking their feet, taking off their socks off, and making sure that their symptoms are caught on time. And there is a bias in medicine when it comes to addressing women. I mean, we tend to ignore it and push it to the side and blame it on other things that are going on in the construct of their lives. But there is true disease that's going on, and the manifestation of the disease too, it differs when we see that in the lab, or when they go for surgery, and we see different types of levels of blockages in different anatomical spaces.
Right, right, right. So someone comes to you. They seem to have some of the signs and symptoms of peripheral artery disease. So how do you go about the diagnosis? What do you do
Right.
next?
First of all, we have to define who's at risk for peripheral arterial disease. So if you are under the age of 50 and you've had a history of either diabetes or nicotine use, in addition to any of those risk factors that Coleman has mentioned today in terms of kidney disease or high blood pressure and high cholesterol, you need to get screened, and take your socks off when you go see your physician and have
Right.
them inspect your pulses. But if you're over the age of 50 to 69, so between 50 and 69, and you have either a history of diabetes or nicotine use, you should also have screening. If you're over the age of 70 without any risk factors, because 1 in 3 of those patients will have peripheral arterial disease, you need to get screened. The reason why diabetes is an emphasis in that 1 in 3 adults will be a diabetic by the year 2050.
Yeah.
And you and I know that, 1 in 3 adults over the age of 50 will have peripheral arterial disease. So those patients have to be screened early on. Lastly, is if you've had plaque buildup in the neck causing stroke, or you've had heart disease or kidney disease on dialysis, you should have your extremities screened with, first of all, your pulses inspected. And the last piece is your family history.
Okay.
Any family history of fat, and if you're obese, I think those things have to be screened as well. Now, what other than checking your pulses, there are other things that can be done. It's called the ankle brachial index exam, where they can check the differences in your blood pressure in your arm and your legs, and they'll take a ratio, and that ratio will determine if you do have either mild, moderate, or severe symptoms. All right.
Okay.
In addition to that, a physician might need additional either, vascular imaging with inducing some form of exercise. They can do segmentals, or they can check, pressures of your toes, or they can do ultrasound or CAT
Okay.
scan. All right. So there are different modalities, but it has to be done by specialists who knows who are vascular trained to pick that up. And once those are done, it determines at what stage do you need to have an intervention based on your symptoms, and plus the additional data we're getting from your non-invasive study. So if you have an ulcer on your feet, you definitely need to have an angiogram, which is eye shot down your legs to see the imaging of your blood vessels on the X-ray and determining how we can clear that path and see how we can go from this
Right.
to hopefully to this, right?
Right.
To open it
Exactly.
up. So that's called an angiogram with intervention, and that can be done either via minimally invasive procedures, or some people do bypass surgery. So those are kind of the treatment options. But what we're seeing as particularly in communities of color, is that when these patients present with either rest pain, or they have this non-healing wound or ulcer, or there's gangrene, they are just offered an amputation first strategy, take off the whole leg. And that is what is not acceptable in 2021.
No, exactly. And you mentioned something. You said a word earlier. I don't know if the audience caught it. You talked about limb salvage.
Right,
And
right. So what is
often, we're African Americans are not offered that. All right, there are all sorts of really amazing procedures now that can help to salvage that limb without immediately going to amputation.
limb salvage strategies have been shown to decrease your odds of amputation by 90%.
Wow.
But out of the 200,000 amputations that are performed every year, 130,000, which is 65%, are done on diabetics. If you're an African American, that's 3 to 4 fold higher if you get an amputation. In some points, even eightfold if you have end-stage renal disease, higher than your white counterparts. And what happens is that when you present, particularly with those symptoms that I mentioned earlier, especially when you have like a wound or ulcer, that angiogram has been shown, right, to try to, if you go in there, you can unclog those arteries and restore some kind of good flow, and get a good podiatrist, get a good pharmacist, get a good wound care specialist, get a good nutritionist on board, try and heal that wound and give it time to heal before you perform an amputation, particularly if it has not involved the bones and in terms of infection of the bones.
Right.
But what we typically see is that these patients will go to any ER hospitals, and there are certain hospitals that have surgeons on staff that love to cut. I mean, they that's what they do. And some of these surgeons are not vascular surgeons; they're general surgeons, they're orthopedic surgeons. And that in itself is not should not be the primary strategy offered. But we're seeing that in 50 to 70% of the time,
Wow.
and across the board,
50 to
that's what's offered.
70%.
Yes, 50 to 70% of the time. Actually, in places like the Delta here in Mississippi, those numbers are as high as 90%.
Wow. So, second opinion, folks, second opinion.
Yep.
So, when anybody
Yeah.
tells you something and you say, oh my God, all right, maybe it's good to get a second opinion, and especially from a specialist, right? Because, as you said, a lot of these things are being done by general surgeons. They're not necessarily vascular specialists. I have been doing this for 40 years, and I can tell you that we've come a long way from
We
where we
have.
used to be
Yeah,
in
we
terms of
have. And
procedures.
Yeah, we have. The problem is not technology. I mean, when you look at what's happening now, and you go to all these conferences, and you see people talking about, this is the technical advancements we've had. We've had advancements in technology that have decreased heart mortality, I mean, death rates from heart attacks for decades. The same thing, we have the technology to decrease amputation rates, but we have not seen the numbers to correlate with the advancement of that.
No,
It does not commensurate. And so
exactly.
what we're seeing is, rather than seeing a decrease in amputation rate, we've seen an increase,
Yeah.
especially in disadvantaged communities.
Yes.
So what is truly in play? That's the question.
Right.
It's not genetics. You'll see some folks, and especially people who do not look like you and I, say, well, maybe it's a genetic thing. Well, there's always a genetic factor in like 5% of a population, or
Right.
10% at best.
Yeah.
But, however, this is not a genetic construct. It's a social construct. It's called the
Yes.
social determinants of health.
Yes.
And so if you have to empower your community by educating them about upstream preventative strategies. What is your diabetes? How do you prevent it from progressing to end stage peripheral arterial disease called critical limb ischemia? How do you make sure that your A1C is treated? How do you know your fasting sugars numbers are? How do you know how to eat right and avoid all those bad foods and processed foods that will get your blood pressure and your obesity numbers up, right? If we can spend a lot of time and resources on that, and we get our school systems better, so the health literacy of our patients are better, right? And economically, they can afford an insurance and get access to quality care. Those are things that we need to invest a lot of time in, not invest on technology to treat people at the end stage. No, that's already done. We already have
Right.
those techniques. The lack of information, the lack of specialty care, the lack of being community centric and patient centered and compassion on top of that, and taking out biases in how we treat patients is what is in play.
Yeah, no, that's so important. And so, just so the audience knows, every Saturday at 10 o'clock in the morning for till 11, we're doing a free nutritional support group. I have a registered dietitian. She's going through our series that we have. It's a 10-week series, then we repeat it, totally free. All you have to do is just go to hovhealth.com. It's right there. It's live, right? So, and she's doing it Zoom as well. So we need to get, I mean, there are resources out there, but we're not taking advantage of some of the resources because we just don't know, right? So I think it's so important. So let's talk about some more symptoms of peripheral artery disease, because I think that people don't know it until they're way far down the street on this thing. So I know that there's some numbness and weakness you mentioned. Any other things that people can look
Yes.
for?
Yeah, there is. So if you take off your socks and you see that, yeah, hey, listen, my toenails just don't look right, right? And it's like, it's like yellow, thick, and it just doesn't look right. We all know what right is and what wrong is, right? If it looks funny, you need to go get it checked out. Two is if there's hair loss, especially those who see significant hair loss in one extremity versus another. If the temperature, if one limb or one leg is, your feet is cooler, very cool or cold, that's a sign that you're not getting good circulation.
Right.
If you have neuropathy or you've been told you got the gout, our folks got the gout, but they call it the gouch down here, right? If you got the gout for a long time and they put you on these medicines and you're taking an aspirin on top of that, and you're thinking like, hey, I have neuropathy, but there's a form of neuropathy that's due to ischemia, not just due to the diabetes. You
Right.
need to go make sure that that's assessed. And if you have those risk factors that I mentioned earlier, those are signs. And if your leg gives out, you go to a Walmart or Kroger, you're shopping, or you go to a big, grocery store, and your leg just gives out on you easily when you try and ambulate, or you have pain radiating from down your thighs. And then in men, we see erectile dysfunction is in play too in certain men due to blockages in their arteries. So those are the other signs and symptoms of peripheral arterial disease.
A lot of men don't know that. You mentioned that. That's a big deal. So a lot of men don't know that. I think that I tell my male patients that if you get your diabetes under control and your hypertension under control, your erectile dysfunction might actually improve, right? And they
Yes,
don't
yes.
understand that that actually is a sign that there is something going on in terms of your periphery. They all kind of go together in terms of nerve damage and vascular damage, right? Yes.
That's why we call it the neurovascular bundle, nerve and vascular. They all go hand
They
in
all
hand.
go together, and so that's if you're having ED, and you might not think that that's a separate, but it's not separate. It's one of those clues that let you know that your body's not operating 100%, and that might be something that you want to check out, especially if you got the cold feet, the hair loss, your toenails, all of those signs that you just mentioned. I think is so important.
Yeah.
We talked a little bit about unequal treatment and amputations. We talked a little bit about getting a second opinion. How about women and birth control pills? I know I had seen another one of your YouTube specials, and you talked a little bit about that whole estrogen replacement.
Yeah. I mean, for the most part, it's safe unless you have those risk factors that are, like nicotine use. And let's spend some time on this because if you and I read a lot of literature, studies, right? And what we see is that, all these studies will say smoking, smoking, smoking. And I was one of these actually before I moved down here 5 years ago, where I'll walk in a room and say, man, do you smoke? Sir, do you smoke? But you come down and you realize that, hey, listen, there's something else in play. A lot of the folks in rural areas actually do not smoke. Like, their grandparents were giving them little snuff. Like,
Yeah.
so they'll answer, I don't smoke. And then you're like, well, but you didn't tell me that you snuff. And they'll tell you, you didn't ask. Right? So when it's nicotine exposure is the key here. It's not just smoking. It's what other forms of nicotine, and you want to highlight that in your triage. So when these patients come in, that's something that my nurses and my medical assistants actually do. Is they walk them through because that is what they know, right? They know that hey, listen, I didn't smoke, but I had other forms of nicotine. And that in itself, with a birth control pill, you have to have that risk stratified because that can increase your risk of vasoconstriction and accelerate your plaque buildup in your vessels.
Okay, all right. Listen, we're going to take just a few minute break here. Let people get up, kind of move around. I usually encourage them to stand up and do some marching in place. Go get a cup of green tea or something healthy for them to eat. And we're going to be don't leave me. I say right with. We'll be right back with you. Hold on one second. Thank you, guys.
Epigallocatechin gallate, superoxide dismutase, glutathione peroxidase. Now, those are names you probably aren't familiar with, but you should be. Those are antioxidants known to fight free radicals. In fact, did you know that some viruses are actually alcohol resistant? One major study showed that by adding the epigallocatechins from green tea, it killed the virus on contact. Please allow me to introduce myself. My name is Mark Johnson. I'm here to share with you an exciting new, technologically advanced, patent-pending green tea hand sanitizing wash from Handout Protection. Now, this is not your typical hand gel designed to just smear all over your hand. This is a hand washing sanitizer to cover your entire hand, both the front and back of your hand, in between your fingers and your wrist. This is a non-sticky sanitizing hand wash designed for convenience to take with you in your purse, pocket, or carry in your lunchbox. As Dr. Josh Ridge has stated, what goes on your body goes into your body. That is why we choose only the highest FDA-compliant ingredients, such as 75% isopropyl alcohol and organic green tea brewed with alkaline water. The only way to protect yourself and your family is to always carry a disposable package of Handout with you. This may be the only handout you ever need.
Hi, welcome back. Welcome back. I know I'm actually looking at my Facebook page. I know there are some of you out here looking at Facebook with me. I can actually see your questions. If you have any questions that you want to pose to either myself or Dr. Fakorede. Oh my gosh, I know I was going to mess it up.
It's all good.
Anyway, I wanted to encourage all of you that are watching that you need to send out right now to your friends to a watch party so that they can watch as well, because we're talking about peripheral artery disease today, and we are really trying to do a deep dive because both myself and Dr. Fakorede is both are interested in stopping this death and dying and this carnage of amputations. So we were talking about peripheral artery disease, sir. We were talking about amputations. So let's talk about some drug therapy. You know, I'm a pharmacist, so I always want to talk a little bit about the drugs. There's not a whole lot of drugs, though. Isn't that interesting? Over the years, right?
Well, you have to look at it from an atherosclerotic standpoint. And for those of you in the audience, we're just talking about that buildup of plaque and cholesterol. We're talking about this, all right? We call that
Right.
atherosclerosis. So that happens in the heart, and you know that the staple for treating atherosclerotic disease in the heart or in the neck are staple. We need what we call antiplatelet therapy, or what our patients call blood thinners.
Yeah.
Although not technically blood thinners because it's antiplatelet, it's not anticoagulant, but it still thins out the blood.
Yes.
And then we have ACE inhibitors and ARBs that stabilize the modulation of the plaque, and then we look at statin therapy, cholesterol lowering therapy. But then we've added, medicine like cilostazol to our treatment regimen that helps with mobility in terms of your range and your distances in which you walk, and increasing your walking distance.
Okay.
It has no role in terms of actually decreasing your plaque burden. It just improves your walking distance. And
Okay.
then you go to supervised exercise therapy, and that is basically an exercise therapy that's 12 weeks program where you can have graded exercise programs to increase not only increase vasodilatory responses, but you can increase the recruitment and retention of collateral flows to other places that have sustained blockages.
Okay.
Then once we get through that, then we go into lifestyle and your dietary modification. Are you smoking? Then you need to stop. Are you using nicotine? You stop. Are you drinking? You need to stop. One glass of wine, right? Not a bottle of wine. Red wine. And then you go into exercise. You need to exercise. I always tell my patients 150 minutes, in a week is what you need of exercise. And then you have to also look at your other habits, like your sleep habits, trying to sleep well, to increase your energy. And then just try and move. Be on the move at all times. Just take the stairs rather than the escalator or the elevator. So those are the things we do first before we start doing procedures.
Yeah,
And
you
their
mentioned
procedures,
smoking. How about vaping?
same thing. Yeah,
See, they
it's
don't
just
think it's the same, but
they
it
know.
is.
Yeah, don't smoke, don't dip, don't chew, don't vape. That's what I tell people. It's all bad for you.
Yep.
And then it's then interventions where you can either need minimally invasive procedures where someone like myself can go in through an IV, and we go in and we unclog that plaque, and debulk it, and restore circulation. And the analogy I use is like, it's like your kitchen sink pipe. Like if it's clogged up, you call the plumber, and the plumber comes and does the roto-rooter,
Right.
and the roto-rooter unclogs the pipes. That's what I do. But if we can't do that, then there are surgeons who can do a bypass. They just bypass where it's open to open. They'll just bypass it with another vessel or another material. And then, those are options that should be offered before an amputation.
Right. You see how many things you said before the amputation?
Let's repeat that. All those things should be offered
Yes.
before an amputation. And even if you present with that gangrene, right? Look at your feet. Everybody should look at your feet when I'm saying this. You're looking at your feet and you're saying, okay, if I were to have a toe that is all black, why are you chopping off from my knee but to all the way down and taking out everything rather than just taking out that one toe?
Right.
Maybe what needs to be done is that the pipes need to be looked at where they've unclogged all the blood vessels all the way down to all my toes. And then if that black toe is still there, and you take off that one toe. Because you know
Right.
what? You are functional mobility with that one toe. You can go to and be productive to the society with that one toe.
Yes.
Once you have an amputation below the knee, 80% of these patients are dead within 5 years.
Yeah.
The cost to take care of these patients, the evils of amputation is the cost to take care of these patients lifetime is close to $500,000. Let me
Wow.
repeat that, $500,000
Wow.
lifetime cost for the patient. The average income of a Mississippian is what, $40,000 a year. How are they going to afford that?
They can't.
The nursing homes, most of them cannot even go to most of them cannot even go home after an amputation. They have to go to nursing homes. And you and I know after a certain amount of days, you have to start giving up your house. A nursing home basically is going to own
Yeah.
everything you own because
Yeah.
that's what happens. These 90% will suffer from chronic pain. And just like that leg that was chopped off without the circulation opened up, guess what's happening in your other leg, the contralateral leg? The
Yes.
same
It's
thing. We
not
call them
that leg.
twins.
It's both.
It's both. So the next year, you will have a 30 to 35% chance of having the same thing happen to that other leg. And so that is what we call the evils of amputation, not to mention the mental aspect, the
Oh yeah.
depression that sets in, the scars. But this is a generational scar because if you look at how diabetes quickly presents, I mean, it's real, as I call it, 0 to 100, real
Right.
quick. That's what happens.
That's
And
what
so that's
happens.
what happens with diabetes. That's why diabetes is an epidemic. 1 in 3 adults are going to be a diabetic. So if you can treat that risk factor, you do not become that statistic that presents to the ER because you waited too long until your foot started turning black. And then you leave it up to the positional power of the doctor to dictate your outcome if you live or if you die.
Right. Oh my goodness. We actually are doing a diabetes prevention program. We started 2 weeks ago, but we do ongoing cohorts. We really
Mhm.
need everybody out there to take the diabetes risk test. You just go to Google, type in diabetes risk test, and if your number's 5 or higher, that means you may
Right.
have prediabetes, especially if you're
Mhm.
overweight,
Mhm.
family history of diabetes, all of those
Mhm.
things. And if you are in that area of prediabetes, we need to have you come do our class now. It's free.
Right.
You don't have to pay
Right.
anything. So we can
Right.
make sure you don't go on to develop diabetes. Because once you have diabetes, then these risks for the peripheral artery disease, the heart attack, the stroke, the kidney disease, all of that happens, right? And
Right,
erectile dysfunction.
and it happens at a younger age. Usually we think, oh, this is happening at, when you're 70, 80, the fastest growing population are octogenarians, so people in the 80s. But no, we're seeing patients who are 40 years old, 50 years old, heart attack. If you
Jeez.
have diabetes and you're a smoker, we're seeing patients in their 30s going for bypass. So it's just, it's now, it's the two unique risk factors that pose the greatest challenges to our healthcare system are diabetes and obesity.
Yep.
And until we address them, because these are epidemics that have been going on for decades, and it's been a public health challenge. Until we address that, and as an African American who sees these patients who present, I mean, and in addition to that diabetes and hypertension, guess what they come with? They come with chronic kidney disease,
Right.
and then they come with, and so the question is, why are these patients not screened?
Right.
So we haven't
We're
talked
not
about that yet.
screening.
How come primary care doctors are not screening these patients? Well, it's not all their fault.
No.
There's a lot of people like, oh, well, every doctor should know all this. It's not actually true because peripheral arterial disease is not well taught in the curriculums of medical schools, nursing schools, all these ancillary schools. It's not well taught. So that's one thing we have to go back and do a better job of treating it. Just as aggressive as we teach heart attacks or pulmonary embolisms, we need to treat and teach about peripheral arterial disease. The
Yep.
second thing is that the United States Preventative Service Task Force is a body that determines basically what preventative screening tests should be done on patients, right? Based on evidence-based medicine. And the U.S. and this is basically the group that a lot of family providers and internal medicine docs use because CMS, the Centers for Medicare and Medicaid Services, are utilizing their guidelines and recommendations of the USPSTF to determine what services they will pay for.
Yeah.
So breast cancer screening, right? You get screened, USPSTF says screen those patients, guess what? The doctors will start screening for that.
Yeah.
Hepatitis C screening. If you're over age of 18, the CMS says, yeah, you should screen for those patients.
Right.
Alcohol misuse disorders. If you're over 18, actually, USPSTF says you should screen. But do you know what they say about peripheral arterial disease? Here's
What
what
do they
they say.
say?
Well, they say that we should not screen the general population for PAD. And that's not what I'm proposing today. I'm saying, what are those patients who are at risk
Right.
that we defined earlier? We need to screen those patients because those patients are disproportionately affected in treatments and in outcomes. And the lack of giving that desired recommendation will perpetuate not only worsen outcomes, but also it's going to lead these primary care providers to be disincentivized from screening. And what they claim, the USPSCF, is that minorities are missing in a lot of research data.
Oh
So
yeah.
we do not have sufficient evidence to determine the benefits versus harms. Now, if you look at all the research trials to date in cardiovascular disease, only less than 5% have included African Americans.
Oh yeah. Oh
Okay.
yeah. No, it's terrible.
So what evidence are you going to find other than what you and I are talking about? We have an amputation epidemic, and you can go to any rural area and you can see it. So the fact that we don't have that evidence should not mean that we should wait another 20, 30 years to get data
Right.
so that more lives and more limbs should be lost.
Yeah. And so
So
I when I'm yeah.
that is why we disagree with their stance, because they need to come out just like we as the American College of Cardiology have said, and the Society of Vascular Surgery and Coronary Angiography and Intervention, the people who treat vascular disease, we have identified the patient population that needs to be screened early on. And those patients unfortunately carry those risk factors at a higher rate if you're a minority,
Right. That's right. And
hence
you
the
know, like we're
outcome.
not aggressive enough with the screening. We're not focused on prevention. We're all about the treatment. But I
Right.
really want the audience to focus on the fact that it's your health and it's your body, and you need to make sure that you are doing everything that you can do to be in control of this situation. So what we're
Know your
doing is
number.
bringing this knowledge to you, man. Knowledge is power. It's a serious business. And so you, all of the signs and symptoms we've given you, we told you what the treatment is, told you about second opinions, told you to seek out specialists. They are available. If you don't know where to find a black doctor, you just go to blackdoctor.org and put in your zip code, and you'll be able to find the black healthcare professionals in this country. We need to be doing a better job. We have to take some responsibility, I think, right? Because you and I can only do so much, right?
Yeah, we do. But one thing we also need to do is to make sure that we as black physicians represent 5%, less than 10% of the medical community. But as cardiologists, we're less than 5%.
Yeah, that's true.
And what you see is that these rural areas or these black census code map that you look at, you just look at the slavery map, and then you can just overlay that with your diabetes belt, your obesity belt, and your adverse heart and vascular disease belt, and the highest amputation rates or lowest revascularization rate, and the
Right.
lowest limb salvage procedures are performed in there. Just how ironic. So what you see is that there are other physicians who work, but in the settings in which they work or the hospitals, you also have the lack of specialty care in certain
Right.
areas like that. So they have to travel 2 hours to see a specialist.
Yes.
And when you're poor, that's a huge factor because someone has to leave the workforce to work. And that is where, from a public health strategy, we always you have to bring the care to patients. You have to meet them where they are. And I think the best thing we can do is of the $200 billion we spend a year on amputations and PAD in terms of treating the bad outcomes, we need to shift those dollars to prevention.
Okay,
And
absolutely.
we
Listen,
need
we have a one of our Facebook audience wants to know a little bit more about you. They want to know where you are. They see the name of your clinic on there. So tell us a little bit about
yeah.
what the name of your clinic and
Sure,
how
sure.
they can get to
So I
you.
am, yeah. So I'm located here in the heart of Mississippi Delta. It's called Cleveland, Mississippi, in Bolivar County. My Facebook page and the name of the practice is called Cardiovascular Solutions of Central Mississippi. And what we do here is that, we treat patients comprehensively for general cardiology, but also patients who need vascular care. If you have to contact me on social media, anything is PAD Advocate handle, or PADadvocate at Gmail is the email. And then the phone number here is 888-757-0838. And that will get you in link with one of my staffers, or myself, and we can address anything you need.
Yeah, because not only are you doing medical care there, but you're doing a lot of community outreach. A lot of, I mean, I went and looked you up there, and I saw that you're doing a lot of stuff in your area,
Well,
just trying to
well,
spread the word.
Dr. Coleman, the key to every community like the one I serve, especially if it's an African American community, you got to know the strengths of that community. And
Right,
the strengths of that community is what? It's going to meet them where they are. It's going to go to the faith-based, going to their churches, going to the women-led groups. African American women are very big on healthcare.
right,
They're big in terms of advocacy on healthcare. They're great community navigators. They will go and advocate for you. And we men, we tend to say, nah, we're gonna wait. No, the women are like, hey, come on. And unfortunately, they're the ones ignored too when they show up to actually get care, because
right.
they actually seek it out. So that needs to be tackled. But it's going to the churches, because it's mind, body, spirit. So I believe in going to churches and talking about this issue. I do not want to see patients in my clinic. I'd rather see you at church, or at Walmart, or or different setting in the community, healthy, and for
Right.
you to come and see me to get care. And the one thing that we do, and we pride ourselves, is that irrespective of your skin color, your insurance status, you will get the same care as the president of the United States. It doesn't matter. So
Right.
that is at the door, and that term is called statistical discrimination, which is basically the notion. There's a preconceived notion in healthcare that any patient who walks through a door of a physician's office, or primary provider, the historical care that has been given to people who look like you is what more likely that provider will do. And if
Right.
it's amputation is the first strategy, they're getting people who look like you, that's what's going to happen. It becomes a generational scar. So that's not in play when you come to see us, and that shouldn't be in play at all. So when we want to talk to our medical schools and our training programs about, basically being more competent in dealing with communities of color, we need to teach them how to address the social determinants of health piece, and be more competent in addressing those pieces, and working collaboratively with people like you, who are in other specialties, to see how we can deliver quality care so that their outcomes are favorable.
Yeah, no, I agree. I agree. So we're getting close to end time here. I just wanted to. I had listened to one of your programs that you had done previously, and you touched on sleep apnea. And I just
Oh yeah.
wanted to just real quick before we end up, I just wanted to talk a little bit about that, because a lot of African Americans, both women and men, because of the obesity, are having a
Hmm.
lot of sleep apnea, and they don't know that there's a relationship between that and cardiovascular disease.
Yes, there's a big one, because with sleep apnea, when you have a disruption in the oxygen exchange in your lungs due to obesity, which is very rampant, overweight and obesity is very rampant. Close to 50% of our population in the African
Yeah.
American community are either overweight or obese. So sleep apnea is underdiagnosed, because these patients do not have enough oxygen exchange, and if that happens for a long time, the manifest with symptoms is fatigue, somnolence, they're snoring, or what I call calling the hogs. They're snoring, right? And
Yeah.
and 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 they get headaches, and they have breathing difficulties at times. They wake up to catch their breath at night, or they stop breathing. And so, if you have any family member like that, or who nods off while you're driving, or you're talking to them, have them evaluate for sleep apnea, because what it does, it can affect these three major things when it comes to cardiovascular outcomes. You can have irregular heart rhythm and subsequently get a stroke, or you can have heart failure, or you can have a heart attack. So when these patients have sleep apnea that's underdiagnosed, they can have atrial fibrillation, irregular heart rhythm, they can have a stroke. Subsequent to that, they can have a heart attack, or they can have heart failure. And so it's important to get them tested,
Right.
or referred to a specialist. And once you treat that, then they can go out and exercise and get that weight reduction they need and get their A1Cs down and their
Right.
obesity and diabetes numbers come down. So rather than us always telling patients go exercise, exercise, no, let's diagnose their problem so that we can give them a fighting chance to exercise right and therefore decreases their risk factors for adverse cardiovascular disease.
Yeah, no, I agree. I agree. So they need to get sleep studies. They need to get a definitive diagnosis. And then there's all
Correct.
sorts of, well, again, technology. There's all sorts of
Correct.
CPAPs and other kind
Correct.
of breathing assistant devices that can be prescribed that can make a big difference. And what they're going to do is when they wake up in the morning now, they're not going to be exhausted, right? Because that's
Right.
what happens
Right.
if you're not
Exactly.
catching your breath all night long, right? You wake up and you're tired and like you
And you
haven't
get a
slept
headache.
at
Right.
all.
Right.
Yeah,
And
yes.
the onus is on them to stop habits too. Like don't drink. You're a drinker. That's not going to help you. Your sleeping habits. You have to put everything off. Avoid caffeine. Our caffeine, that sweet tea. Now we're close to the end, so I can say this. Oh, we got to watch our sweet tea intake, man. I mean, it's we got to do something about that.
Yep,
And I
yep.
know people don't want to talk about it in our community, especially in our churches, but I say it everywhere I go. Sweet tea is dangerous to our health, especially when it comes to the sugar that we're trying to battle.
Right, exactly.
So, and everything has to be done in moderation. Processed foods, fried foods, we have to cut it down. And the Mediterranean diet is a good diet that we advocate as cardiovascular specialists, and plant-based diet and the DASH diet for people who have high blood pressure. Those are the
Right,
only three I can talk about. I cannot talk about any other diet.
right. Yeah, no, and I want to just say that again. So, Mediterranean diet is really good for those people who have high cholesterol, etc. The DASH diet is dietary approaches to stop hypertension, right? So that's
Yes,
what the
ma'am.
DASH diet is.
Correct.
So, that is a great diet. Actually, that diet for African American men actually showed some real benefit, and because they
Yes.
actually had more milk in that diet. And if you have lactose intolerance, you can get milk that doesn't have lactose in it, folks. So you can still drink your milk. And so there has been something about that as well. So all of those diets are really important. Plant based. I'm trying to eat more plant based. There's some
Right.
hamburgers out there that I've been getting that are plant based that actually you would not know that it's not a regular hamburger. So I'm trying to kind
Right.
of back off my meats and eat more fish, more chicken, more turkey. So, all
Exactly.
of that is there. And we're here at Healing Our Village to help you with that. Like I said, we have nutritional support. We have something called Village Club where you can join for $5 a month and you get access to all of my health professionals. So for, information about that, please call our 800 number, 800-788-0941, or go up to our website, hovhealth.com. I want to again give you an opportunity to let people know how to get you, especially if they're down there in your area in Mississippi. So tell us again the name of the clinic and phone number.
Sure. Either Google the name or the phone number is 888-757-0838 and padadvocate@gmail.com or Cardiovascular Solutions of Central Mississippi is the name of the practice. And my IG, Instagram handle or Twitter handle is PAD Advocate.
Okay, PAD advocate, huh?
Yes, ma'am.
Got it, got it. Thank you so much. Any closing remarks just to let us know about what we should be doing about PAD that you want the audience
Yeah,
to know?
in 1966, the Martin Luther King Jr. said that of all forms of inequality, injustice in healthcare is the most shocking and inhumane, and that still holds true today.
Yes, it does.
And we as a community that has been disproportionately affected in treatment and outcomes have to realize that we have to take over that power. There's a difference between position and power, and we need to stop depending on those with positional powers and empower ourselves where we can be advocates for our care. That starts at home. Make sure that we do the right things so that we do not become those dismal statistics that the whole world is waiting to see happen in our communities. And then, we need to do a better job in our pipelines of trying to get our youths to get interested in the science, in the STEM programs,
Yeah.
science and technology and mathematics and engineering, and let them become the future that will help move this path and shift that social determinants of health metric to one that's favorable for us all. So thank you very much, and God bless everyone.
Yeah, thank you so much. And again, this has been excellent, right? This is our third series of this month. This is Heart Month. Trying to talk about cardiovascular disease. That's what's taking us out. If you're African American, what's taking us out is cardiovascular disease, mainly due to hypertension, out of control. Our blood pressures are too high for our kidneys and for our eyes and for all the nerve, everything in our body is affected by these high pressures. We have to do a better job. I encourage you guys, this what we did today will be posted up on my website, and we're going to give it to you to post up on your Instagram as well, so that we can get the word out. Thank you so much. I hope to be able to work with you in the future to get the messages out here to our community. You're doing such a good job. I truly appreciate your time today. And thank you, everybody, for tuning in to For Your Health from Healing
Thank you,
Our
Dr.
Village.
Coleman. God bless you. Thank you.
It's a brand new morning, sun is shining.